we just wanted to share with you today the work we've been doing in Aneurin Bevan Health Board to highlight that reducing the environmental impact of inhalers is really so much more than just switching meter dose inhalers to dry powder inhalers, and that by improving asthma care or respiratory care in general, that you know what's good for the patient really is what's good for the planet. Next slide, please, Vicky. So just to really put it into context, it's probably worth just reflecting on what is the problem with inhalers. So some of you will be aware that meter dose inhalers contain hydrofluoroalkanes, which are propellants and greenhouse gases with a global warming potential of anything between 1,000 to 3,000 times more than carbon dioxide, which is the reference product. And in the UK, 70% of all our inhalers dispensed are high carbon MDI inhalers. And the biggest proportion of those is salbutamol. Another problem with inhalers is that patients often have poor inhaler technique, and the critical study in 2017 highlighted that 70% of patients make one or more critical errors with MDIs, but also with DPIs. So this is why we shouldn't really have any wholesale switching of an MDI to a dry powder if we can't be assured that the patient can use that device correctly. Now, I'll caveat that with saying that the MDI device is the one where most errors are made. So we've got a great opportunity to switch those patients that are currently prescribed MDIs that are using them incorrectly to a dry powder device. And like Simon has just said, that really most of this MDI-driven prescribing is just what we've really been used to in the UK, and it's sort of clinician driven in that that's our default position. So we just really need to change our mindset with that as well. And then maybe the reason why we've got such poor technique is that as healthcare professionals, we can often be poor teachers. So this is a call to everyone that whether that you prescribe, dispense, or teach inhaler technique, then we really should be making sure that we can do it correctly as well. This study from 2010, so it's quite old, I'd like to think we've improved on this now, but it was really telling that out of 150 healthcare professionals from all professions, that was primary and secondary care and different professions, whether that was GPs, pharmacists, nurses, or consultants, that 70% had the wrong technique for using an MDI device. And probably more alarming was that only 7% could correctly demonstrate all those steps and the correct inspiration rate. But 3/4 of those that were surveyed were regularly involved with teaching inhaler technique to patients. So this is part of the problem. And that whether it's a dry powder or an MDI, we do need to be making sure that we can teach that technique correctly. And Vicky will sort of provide more information on this later with the app that she's developed. One of the biggest issues with inhalers is that SABA is overused. And in a way, we're focusing on switching dry powders or MDIs to dry powders, but the biggest focus, I feel, should be on reducing SABA over-reliance. And this is the reason why, that we know from the Sabina study that having 3 or more SABA inhalers in 12 months, it's associated poor asthma control, twice as many asthma exacerbations, and then increased healthcare visits. So we know from the National Review of Asthma Deaths that there's a proportion of those deaths that could have been avoided if we were addressing SABA overuse. And then in asthma, the Sabina study also demonstrated that 83% of the SABA prescriptions that we prescribe in the UK go to patients that are having 3 or more inhalers per year. And that's responsible for 2/3 of the inhaler greenhouse gas emissions. So if there was ever a call to just focus on one thing, then I think it's trying to tackle this SABA overuse. But we do need to look at the other things too. Next slide, please. And it's not just looking at inhalers. The important thing is also to make sure that we do take this as a holistic approach, because you can see from this graph, which came from the Sabina carbon study, you've got the grey bars there, which are looking at the total emissions for an asthma patient, for controlled and non-controlled asthma, and the blue bars within them are the percentage of those emissions that are related to SABA overuse. And you can see that at all steps of the BTS guideline, that a controlled asthmatic has a much lower carbon footprint than someone that's not controlled. So it's important that we do take this into consideration. And obviously, if we focus on good patient care, we will be able to drive down some of these emissions. Next slide, please. So we'd already been made aware of this today. The NHS Wales Decarbonisation Strategy was published in March last year. And the aim is that we have a net zero Welsh public sector by 2030. And Natalie has already taken us through some of the recommendations. And this is just a reminder again of those that are related to specifically to inhalers. And it's really pleasing that this document does recognise that we should be taking a patient-centric approach and optimising inhaler use, and also, you know, focusing on this reduction in the over-reliance of blue inhalers, as well, obviously, as moving towards lower carbon inhalers. So that's your dry powders and soft mist devices, and also to encourage responsible disposal. Next slide, please. So in Aneurin Bevan, taking that all into consideration, we wanted to make sure that when we were looking at this strategy, that our clinicians could take a holistic approach to green inhaler prescribing. And so myself, Vicky, and Lloyd Hambridge developed this document, which really, the aim of this document was to raise awareness of all the resources that can help us achieve these goals. And we've put this together to just link interactive. You can download the document, or they can access it on our intranet. And the buttons are all interactive. It will take you through to the relevant documents. But basically, there's some sort of common themes, and Richard has mentioned much of these in his talk. So first of all, it's choosing the right device. Then choosing the right medication. So we've got the All Wales guidelines to help us with that. Not mixing device types. So we've heard that before. If they're having a dry powder as their maintenance therapy, why are we then giving an MDI salbutamol device? That we really should be making sure that the inhaler technique is the same for both of their devices. Then links to optimizing their inhaler technique. If we are prescribing meter dose inhalers, we shouldn't really be prescribing those without a spacer. Improving asthma and COPD control. So that's empowering the patients. So by signposting them to the asthma and COPD hubs, and there's also the asthma for parents hub. And then to really target this over-reliance on SABA. Again, and we're going to hear later about this, about minimizing the propellant in MDIs. And we've already talked about switching Ventolin Evohaler to Salamol because it's a lower propellant. But also, if you've looked at the All Wales guidelines for asthma, you'll notice that at that step 1, that, for instance, if you are going to prescribe an MDI, then it says Clenil 200 rather than the Clenil 100 that we would be used to. And this is because if we use fewer puffs of a higher strength inhaler, then that inhaler can last for longer and obviously has a lower impact on the environment. Obviously, that strategy is only going to be as good as the patient not over-ordering, which comes on to the next bit about reducing waste and really encouraging the patients to not over-order, and maybe explaining the rationale why. And then encouraging patients to return used inhalers to pharmacy. So it would be great if we had widespread recycling schemes, because that's the best option. But while we haven't, then we do need to ensure safe disposal of these inhalers, because the propellants in the meter dose inhalers, if we put them into landfill, those propellants can still leach out into the environment and contribute to global warming. Next slide, please, Vicky. So that's what we've done on an Aneurin Bevan scale, and Vicky will be talking to you more later about the app. And we've communicated that, we've done lots of presentations, but I wanted to take that, the principles of that, into my own practice and look at a sustainability project. And with this project, we discussed in my practice all the things that we could potentially do to address SABA over-reliance in asthma, and then mapped these to the principles of sustainable healthcare, which are prevention, patient self-care, lean pathways, and low carbon alternatives. And we found that there was quite a few ideas that we can sort of link into these sort of sustainable healthcare principles. So for instance, improving diagnosis, particularly for those who are on SABA alone. Sometimes they get given a SABA for a cough, and then it ends up on repeat sort of indefinitely, and we really need to address that and stop doing it. And then optimizing medication to prevent asthma attacks. Too many people left on sort of step one of the pathway, using lots of SABA when really they need to be stepped up, and using MART regimes, so one single inhaler as a maintenance and reliever treatment to try and prevent this over-reliance on SABA. Empowering patients to upload the apps, and then looking at implementing the NHS All Wales guidelines. So we put these posters up in all practice rooms. And it was a bit of a sort of a shift for some of the GPs who were just so used to prescribing MDIs. So obviously this has only been recently, so time will tell whether that has actually had an impact or not. But then we looked at what happens to when a patient requests a SABA prescription, sort of from request to issue. And we did a process map for that, and to look at opportunities for patient identification and intervention. And then obviously when we were addressing this work, some of those interventions that we've already talked about, preferentially using the low global warming inhalers, and then when prescribing SABA, choosing brands with a lower volume propellant. Next slide, please. So what we decided to do, and it was something that we had, or I myself had started to do just on an ad hoc basis within the practice anyway, over the last year or so, was to look at addressing this SABA over-reliance and trying to find patients who were having 3 or more SABA in the previous year, and just on an ad hoc basis, reviewing them. So we found that from the process map that this would probably be a good way to target these patients. So the prescribing clerks actively flagging those patients that were requesting more than 3 in the previous year. And these requests were, we do still have some asthma patients that have SABA on repeat. So it was a mixture of whether it was an acute request or a repeat request. And then the practice pharmacist, so myself, and I'm also lucky that I've got another practice pharmacist in the practice, that we telephoned the patient 5 to 10 minutes, quick telephone call, to really establish if that prescription was needed or whether it was actually being over-ordered. So then what we did was, if it was on repeat and not needed, it was removed from repeat. And we had the opportunity to discuss environmental issues with the patient and signpost them to the NHS Wales app if they weren't already using it. And if they said that they actually needed their SABA, then it was an opportunity to just discuss some of the signs of poor asthma control, signpost them to the asthma app, and then book them in for ideally it was a face-to-face appointment, but some of them we did do by telephone, for an asthma review. And where possible, the SABA was changed to a lower carbon alternative. So that was switching a Ventolin or salbutamol MDI to Salamol. Or if the patient was also having their maintenance therapy as a dry powder, we switched there was an opportunity to switch the salbutamol to a dry powder device to match their maintenance therapy. So we decided then to just really collect this data over 2 weeks, so that the project went on for longer than that and is still going on. But we just want to do a data collection over 2 weeks, just to establish what the proportion was of patients who were over-ordering or compared to needing that prescription. But what we've done since is that this is now, these sort of telephone slots are added daily to the pharmacist workload. Next slide, please. So these are our results. So just a caveat that some of this information, you might look at it and say, oh, well, the timelines are different. Some of this reflects the work from when it first started. So you can see that in the chart at the top, we've gone for a whole year comparison. And you can see that my surgery has had a much greater reduction in SABA prescribing. So that's 14.3% or 1,042 items, which is greater than my cluster, Caerphilly North, and also Aneurin Bevan Health Board as a whole, and then on an all Wales basis. So it clearly shows that something different's been happening in my practice. And then we had the benefit of to use the dashboard provided by AstraZeneca from, it was a medical education and goods service. So that was installed in July 2021, but we really didn't use it very much because obviously then we had sort of the second phase of the pandemic. But back at the beginning of this year, I started a spheric project with Cardiff and Vale Health Board, which is, it's like a sustainability scholarship to look at sustainable projects. And we started using it for this. And then this is the sort of some of the things that we've done. And obviously this will continue to sort of map and follow this trend line. But overall, over the last year, the SABA carbon savings are 28,000 or nearly 29,000 kilograms of carbon dioxide equivalent, which is the same as driving a new average car 156,000 miles. So it has made a huge difference. And patients prescribed more than 3 SABA has reduced from 43% in April 22 to 34% in July 22. So yes, we've still got work to do, but we can't, these are not switches that you can necessarily do overnight. This is about educating the patient and making changes and optimizing their treatment. And what was interesting was that 25% of these SABA requests weren't actually needed. And there were various reasons that were given for that, whether it's the pharmacy was ordering on my behalf, my husband or daughter ordered my prescription and didn't know I didn't need it. So it was really useful for that telephone conversation to just have, just to sort of just educate the patient on maybe not and thinking twice before they ordered something that they didn't need. Next slide, please. And just because today, obviously being sponsored by the AWTTC, I thought it would be nice just to show the Decarbonisation Dashboard for my surgery. So when you look at our proportion of dry powder and mist inhalers, yeah, it isn't great. It's only 34%. That has increased. We are working on it. But as I said, this takes time and will need that sort of inhaler technique assessment with patients. And then what I'm really pleased about, though, is if you can look at our sort of carbon footprint and the trend graph, that really has reduced, which is reflecting all the work that we've done. So I'll now hand over to Vicky to tell you about her app. Thank you.
Thanks, Jackie. So I'll try and go through this super fast, sort of overview it. So the main reason behind looking at this was we've got all of these bits of really, really valuable information. Like we need to look at how many doses we use. Can we increase the strength and lower the number of doses we're using? Can we change them and get them off the SABAs they don't need? Can we map over the devices? And it's like so many things we need to do. How can we do all of that in one place? So I've been looking at for some months now, nearly coming up a year, is how we can use technology to support all of this decarbonisation. The idea being we're not fortunate enough to have a Jackie in every surgery. So how can we do it so you don't need that level of knowledge and able to do these inhaler assessments? So we've got an app which we are just running through the final sign-offs for, and this is what it can do. So what it does is look at what inhalers you're on at the start, and it combines them into a fewest number of devices as possible. So if you're on 2 separate inhalers with single drugs in, it will look at putting that into a dual of the same combination of strengths. So if you've got an ICS, it will always map the ICS strength over. It can select a device which is best suited for the patient's inhaler techniques. We would be looking at if they can use a dry powder, that is all it will offer, therefore promoting dry powder first line. it prioritises the low global warming potential inhalers. So if you are a patient that can only use MDI, it will prioritise in the list of options ones which have committed to or use carbon global warming potential propellants, if you like. So it would never offer you Ventolin, it would always offer you Salamol. It'll match your SABAs to your regular inhalers by device where a SABA is indicated. So it'll ask you if you need a SABA, and it'll prompt you to say the guidelines say you don't give a SABA unless the following situations. And it'll also then, if you're using a SABA, promote using a spacer. So it'll offer you an appropriate spacer, so either one with mask or without, depending on the questions that the patient has answered. It'll also push to MART in line with the guidelines. So if you've got a patient who's massively overusing that SABA and they're in that proportion of the guidelines where MART would be appropriate, it will offer you a MART device, and then it won't offer you a SABA to be selected. And it also, for CPD patients, considers the resistance of the device, which is something we always struggle with. So your patient might not be getting the benefit because they've got the right technique, but they haven't got enough inspiratory flow to get the full dose out. So there's questioning specifically that then the app will look at devices of the same combination, lower resistance than the current inhaler. So what it can't do, so this is a decision support tool. It's not meant for diagnosing and things like that. So it can't look at conditions that aren't COPD or asthma because it does it off the licensing. It can't step up your uncontrolled asthmatics, and it can't step them down if they're well controlled. And it can't optimize combinations that don't respond to the license indications. If they've got a combination which is kind of off license, it doesn't know what to do with that. So it will flag up an alert saying you need to refer them to a respiratory specialist. And it can't make the clinical decision. So it would still need the professional knowledge and understanding to be able to look at and see what is appropriate for that patient. So just very quickly on where the data we use comes from. So the ICS classifications of strength are from Rightbury, so there's a consistency there. The device resistances are all by the injectile grading. So again, there's consistency there. We use EMC for the license indications, and the global warming potential is primarily used from the All Wales guidelines. You're asked before you start to just click off. So this is how the app looks. So you're confirming that your patient is over 18 because this is for adults only. It's too complicated for kids. And there's a disclaimer page that says it's a decision support tool. So this is because it's not classed as a medical device by the MHA. If it's decision support, all it's doing is basically digitizing the All Wales guidelines and including some additional stuff from other reputable sources around how you decide on whether or not they've got the appropriate technique. So put in the patient's name and NHS number. There is a bit on there for the NHS numbers, has to be the 10-digit number, otherwise it doesn't let it progress to another screen. This is the inhaler selection screen, so it's got all of the regular inhalers that people could be on in there. So you pick the one they're on, and then you get confirmation screen, and then depending, it's quite adaptive. So if you've got an asthma patient, it will ask you these two screens of questions. So whether you're on MART and do they overuse their SABA, and then how often are they using it? Because we find with asthmatics that you're not using it every day, which is, I just use it when I feel bad, which is more of a push to MART. Whereas for COPD, you ask if you use them, and you get asked about, do you get a benefit and how long does it last? Because that's more of a looking at the resistance. So you're asked to check about how you use the inhaler, because there are often loads of critical errors around priming. So if you click yes there, a box is open to add the comments, and then you've got the assessment screen. So this asks you about slow and steady, forceful and deep, and a breath hold at the end. And depending on the outcomes of that, if you pick, so yes to forceful and deep, that means you can do a dry powder, provided you can do a breath hold at the end, because if you do the most appropriate inhalation in and then breathe straight back out, you've lost everything on the out breath. So it kind of things that we need to consider. So if the answers are yes to those, it'll select the right inhaler, and it'll do that based on the guidelines, and it'll pick the lowest global warming potential one first. What you get at the end of it is a summary screen. So this is like an example run. So this is I always run my husband's inhalers through as an example. So if they were overusing, so he would on a Clenil, on a Ventolin, not MART, not using a spacer, only uses them when he feels like it. So he's overusing the SABA. So you've got the SABA warning here that comes up because he said yes to overusing. So could do all the techniques. So was appropriate for a dry powder. And therefore was given a choice. So there will be a selection, which then as a healthcare professional, you can discuss with the patient, and was picked to do a Symbicort. So who can use it? So the idea of this, I don't know why it's gone back a page, there we go, is that it would be used by healthcare professionals across any of the sectors. So currently this is an Aneurin Bevan. Pilots will look to sort of verify some of the content, if you like, and then we would have it used everywhere. So it could be used in secondary care for anyone that comes in on an inhaler, primary care for anyone that would see patients and assess their inhalers, or even potentially community pharmacies when they're doing research. So, you know, good practice like JDS Evans, perhaps this would support what they're doing there. It does collect the data. Everything that sits in Microsoft 365, so cybersecurity are happy with that because you can't get anything out of that once it's in there. But we can use the data then to see where the engagement's coming from, prescribing trends, carbon savings, and even cost savings. I don't have time for a live demo. We would like to, future development, get it to do a PDF copy that you could upload straight to your patient record. So at the minute you could print the summary screen, but not everyone has patient notes. That's more of a hospital thing. Has anyone got any questions?